Good afternoon. Greetings from Hinduja Hospital and Beach Candy Hospitals. My name is Rajesh Rajani, and I'm very thankful to Dr. Thomas Alexander and Ajit Mulasiri for giving me an opportunity to speak and interact in this never-ending, beautiful, evergreen meeting of STEMI, which is so consistent. My topic for today is non-culprit vessel in STEMI, the current strategy and role of imaging and physiology. Let's do justice to this talk. Now, what is a culprit lesion? What is a non-culprit lesion? A culprit lesion is defined as a lesion involved in acute myocardial infarction. Any lesion in the entire coronary tree outside the culprit lesion is defined as a non-culprit lesion. A non-culprit lesion may be an obstructive lesion or a non-obstructive lesion. So as per the interclamas study which we have, significant non-culprit lesion was defined as any non-culprit lesion with angiographic stenosis of more than 70 or 40 to 70% angiographic stenosis with the FFR of less than 0.8 or an OCT showing fibrous cap thickness of less than 75 microns with 2 to 3 features of plaque vulnerability, which are minimal luminal area of around less than 3.5 millimeter squares, lipid arc of more than 180 degrees, and clusters of macrophages. Now, this slide shows the evolution of non-culprit artery revascularization from 2000 on 2020, the present era nearly. The evolution of non-culprit artery revascularization over the years has been presented. And in 2010, the initial guidelines suggested culprit lesion revascularization only, nothing else. This concept evolved after the results of primary trial in 2013, which suggested complete revascularization at the index event. Then the culprit in the Dynamite 3 trial suggested stage complete revascularization rather than index event. Dynamite 3 also used physiological assessment studies for non-culprit lesion evaluation. In 2017, compare acute study for complete revascularization, at index or operator discretion and used FFR with a class 2A indication. However, in 2019, complete trial suggested that complete revascularization can be done in hospital either as a stage procedure pre-discharge or in 45 days. So the current guidelines for STEMI as per 2021 ASCCH and SCAI is that the class 1A indication was stage PCI of significant non-culprit artery and class 2B indication of index event PCI. So this basically sums it all. And if we go forwards, this slide shows the guideline table apart from the above two indications, also mentioning that in STEMI with cardiogenic shock, routine PCI of non-culprit vessel should not be done during primary PCI because it becomes too complex and may probably harm the patient. Now, a recent meta-analysis published in April 2021 included 10 different meta-analyses found that complete revascularization is more efficacious than culprit vessel only PCI, as there was reduction in repeat revascularization and non-fatal MI. So what are the facets to be considered over here? What is the timing of intervention and the role of imaging and physiological assessment? These are the two important points which we have to consider. If we look into this slide, we have the pros and cons for immediate multivessel PCI and stage multivessel PCI. Now let us consider immediate multivessel PCI. You got potential prevention of recurrent ischemia and infarction and decreased hospital length of stay. That's an advantage for us. And what are the downsides? You got prolonged procedure time and increased contrast volume for immediate one and poor assessment of non-culprit vessel, which for immediate. So these are the two important points. And as we consider stage multi-vessel PCI, we have time to assess benefit versus risk of PCI for non-culprit vessels and potential use of non-invasive testing. And what are the downsides? Additional risk of PCI excess and procedure cost. And the late stage PCI may not be beneficial. So this again sums up what the gist is coming to us in our minds. Now we have two imaging and physiological studies, the FFR guided strategy versus angio guided strategy. What do we have over here? The recent article published in July 22 concluded that in patients presenting with STEMI and multivessel disease undergoing primary PCI, complete revascularization have better outcomes compared to culprit only. Furthermore, the strategy of angiographic guided complete revascularization ranked as the best revascularization strategy in those patients. A recent study published in JACC in March 22 also revealed FFR guided complete revascularization was not superior to angio-guided complete revascularization and reducing the adverse effects, or events rather, sorry. The full revasc trial, the FFR versus angio-guided revascularization of non-culprit artery, published in American Heart Journal in 21, enrolled 1545 patients. It found that 1 in 5 of angiographically significant lesions were reclassified as non-flow limiting by FFR. Considering lesions of intermediate severity, half were reclassified as non-flow limiting by FFR. Overall, 40% lesions were spared from potentially hazardous revascularization procedures. So to summarize in short, the trial concluded that the FFR-guided complete non-culprit revascularization following primary PCI in patients with multivessel disease can reduce all-cause mortality, myocardial infarction, and unplanned revascularization. That is the most important gist of this particular article. Then we have the Flower MI trial, whose results were published in 2020, in which patients were randomized between FFR-guided versus angio-guided complete revascularization, and suggested that FFR did not yield additional clinical benefit and was found to be more expensive. A recent review article on Flower MI trial published in August last year, which also said that FFR-guided strategy was not superior to angio-guided strategy. The Dynamite 3 multi randomized study published in July 2020 suggested that no significant prognostic benefit to prophylactic complete revascularization of non-culprit stenosis in patients above 75 years of age, which is an important point. This slide basically shows subsets of ACS with cardiogenic shock and ACS with multivessel disease and STEMI. So if you have a culprit, we do it immediate in both. But if you have a non-culprit, then you basically have a deferred, which would be safer, either pre-discharge or within 45 days. And basically to avoid in a situation of cardiogenic shock, especially when the culprit is left main or proximal LAD with a syntax score of more than 22. So this slide also gives us a flavor of both cases in cardiogenic shock as well as in non-cardiogenic shock subsets. Now, what is the role of imaging? Now, we have few months back in 2022, April, a study published in JACC named Erosion 3, which evaluated the efficacy of OCT-guided reperfusion in STEMI. The aim of the study was to test whether optical coherence tomographic guidance would provide additional useful information beyond that obtained by angiography and lead to a shift in reperfusion strategy and improved clinical outcomes in patient with ST elevation myocardial infarction. The study noted that the plaque erosion was observed in 26% and plaque rupture in 66%. And to conclude, it was noted that under OCT guidance, rate of stent implantation was less during primary PCI. So to summarize, revascularization is indicated in patients with plaque rupture with hemorrhage and dissection, and conservative strategy can be considered otherwise in cases of calcific nodule, spontaneous coronary dissection, plaque erosion, and epicardial spasm. This meta-analysis published in March 22 echoed the findings from previous RCT and Flower MI. Complete revascularization is superior to culprit-only revascularization in patients with STEMI and multivessel disease, but routine use of FFR does not improve any clinical outcome of complete revascularization as compared to angiographic approach. So we basically have other modalities which are there, like coronary computed tomography, which can visualize all the 3 coronary arteries and the branches, but is limited in evaluating basically the patients undergoing this particular procedure. What are the future trials? We have 2 trials which are awaited regarding the future of this. The Quadamore trial, which assesses quantitative flow ratio versus angiography for assessment of non-culprit lesion ACIs, and the results are expected in 2023. An interclamide study, a multi-central prospective randomized trial of OCT-based versus physiologically based FFR, IFR, or RFR treatment of intermediate 40 to 70% diameter stenosis at the quantitative coronary angiography. Non-culprit coronary artery. So non-culprit coronary artery lesions in acute coronary syndrome patients undergoing coronary angiography. Primary results are expected probably in 2023. So what is the take-home message we have? Complete revascularization is better than culprit-only revascularization, preferably in a staged manner before hospital discharge or within 45 days. Angiographics guided strategy is better than FFR guided strategy for non-culprit lesion. An OCT-guided reperfusion strategy was associated with lesser rate of stent implantation for non-culprit coronary artery stemi, which is erosion 3 trial. Ladies and gentlemen, thank you for your attention.